Hello everybody, welcome to week 5 session 9 of the Elastoplast movement and taping series. My name's Simon Russ. I'm the head physio at the Plus 500 Brumbies down in Canberra. So we play in the Super Rugby competition and hopefully we'll be again shortly. So I presented last Thursday evening on shoulder prehabilitation, rehabilitation and shoulder strapping. And hopefully that was useful for people that watched that one. This evening I'm going to talk about another topic that I find interesting and something I see a lot in my work at the Brumbies and in rugby at the moment. So that is tendon injuries and tendon rehabilitation. So we're going to go through what tendons are, injuries that happen to them, and my thoughts on how to rehabilitate them, because I think they can be a little bit tricky sometimes, and I'm hoping that the principles of how to rehab them you can apply to whatever sports you work in and different types of tendons. So we'll go through all of that. I'll show you some exercises that I use, and I'll show you one of the rehab plans that we're using at the moment for someone with an Achilles tendon injury. So if I just share my screen to start with. Actually, before I do that, so I've just got to read out the housekeeping. So for this session, I'll keep it under 45 minutes, similar to last week, and the same as the other ones. With this, if I can get you just to hold all the questions to the end, so you'll see you've got a chat function. So if you just want to type any questions in the chat function, I'll answer them when we get to the end. If you could just put all of your microphones on mute, just so we don't hear any dogs or children in the background, that would be great. The disclaimer with all of these things is always a disclaimer. So always read the label, follow the instructions for use, and if systems persist, talk to your healthcare professional. As you know, all Elastoplast products, you can get them at your pharmacy, local sports wholesaler, or elastoplast.com. All right, excellent. I'm just going to open up a PowerPoint because I want to show you a couple of pictures to start with. So hopefully that's come up. So yeah, so again, what we're going to do this evening is we're going to talk about tendon injury and rehabilitation. Specifically, I want to go through some anatomy and some principles. So what we want to go through is what a tendon is, because obviously that's reasonably important. Tendon injuries, I'm going to talk about 2 different types of injuries. We'll go through a rehabilitation, like I said, and I'll show you exercises that I use for 3 different tendon injuries, so 3 different joints. So we're looking at Achilles tendon, a patella tendon, and a supraspinatus tendon in your shoulder, because I think they're the most common ones. But equally, you can apply these principles to any tendon in the body. And then I will show you a little bit of a plan, how I put a rehab plan together for a tendon rehab. So I think the most important place to start is what is a tendon, because I think it can be a little bit confusing at times. What we need to remember is a tendon attaches muscle to bone. Okay, so all muscles have some sort of tendon that are attaching it to a bone. So you can see on the right-hand side, hopefully it's the right on my screen. That's the Achilles tendon. You can see you've got 2 calf muscles, your soleus, your gastrocnemius has been removed here, blends into a long tendon that attaches it to the bone. Okay, so the main job is to form an attachment from contractile muscle tissue into bone. Okay, without going into too much small cellular anatomy, I think it is important that we have a quick look at this. So this is a slide of a tendon, and I think we need to understand very, very quickly a little bit about what they're made up of, because that then we can understand what we're trying to achieve when we do our rehab programs for tendons. So tendon has collagen fibers, so that's these long, white, straight fibers that are going up and down the tendon. They've got tendon cells, which are called tenocytes, which are all these little black dots, which are really important, because what we're trying to do with our rehab is we're actually trying to influence what the tendon cell does, which I'll show you a bit later. And then ground substance. So ground substance is all this extracellular fluid that sits in a tendon. I think that's really important, because you'll see shortly we don't use the term tendonitis anymore, and I'll explain why we don't when we get to that, because it kind of gives us a bit of information and guides what we do with our treatment. Oops. All right, so tendon injuries. There's 2 big ones that we're kind of looking at. So tendon ruptures that are usually like a specific incident. They result in a loss of power and function, and I'll show you clinical tests for those. And then predominantly today, we're going to speak about tendinopathies. So they're really, really common. They exist on a continuum that I'll show you, and they can be really challenging to treat. And that's why it's one of these topics that I quite enjoy talking about, because I think they can be a little bit resistant and they're a little bit challenging sometimes to get back to playing sports. They can niggle for quite a while. So I'll show you my principles that I think are important when you're trying to rehabilitate these type of injuries. All right, so tendon rupture, like I said, it's almost always an acute episode, so people will remember something happening. So they will say, bang, something happened and I lost function and I lost strength. So if we're talking an Achilles tendon, the back of your ankle, they, for example, often will say, so the most classic example of Achilles tendon injury, the most common story is, I went to push off. So I was playing tennis, I went to push forward and I felt something happen. They would usually, it's not always painful. A common description is, I felt like somebody hit me in the back of the leg with their tennis racket and I turned around and there was nobody there. So they have an acute episode and they have loss of function and strength. So if you rupture a tendon, obviously there's no connection between the muscle to the bone. So if you rupture the tendon and you're not having the pulling on that bone, you lose function and you lose strength. So if that's an Achilles tendon, you lose the ability to push off through your foot. Okay, if that's a tendon in your shoulder, you might have an acute episode. I went to lift a bag of shopping, bang, I felt something go in my shoulder and I lost function and I lost strength. So I wasn't able to then lift my arm up. Oop. Sorry, that should have come back on. So yeah, so shoulder injury, I had an acute episode. I went to lift a bag of shopping, bang, episode, my shoulder function reduced and my strength reduced. So they're no longer attached to the bone. I can't lift my shoulder anymore. And depending where the tendon is, you might actually be able to put your hand on a palpable defect. So certainly through your patella tendon or your Achilles tendon, it will look unusual and you might even be able to feel a little bit of a defect. So I've just put a question there, how might you rupture an Achilles or a patella? I think the answer there is by overloading it. So the mechanism is too much load for a tendon. All right, tendinopathies. I realize this slide looks really busy and can be a little bit hard to see, but it kind of sums up everything we're going to talk about with rehab. So if we just start with this square box in the middle that says normal tendon, what you can see here, so this is from Jill Cook and Craig Purdom, are two excellent physios and experts in tendons, and they've kind of rewritten how we manage tendons. And what I want to look at is just this little part in the middle to start with. So if you have a normal tendon, you can see what happens. Let me just move this. If you optimize the load, you get an adaptation. The same as any structure in your body, any system in your body. If you exercise, you get better at moving blood and oxygen around your body and you adapt to it. So same with the tendon. If you optimize the load, the tendon gets stronger and can handle more. So you get strengthening and you have a normal tendon and you can continue, and ideally you continue in this cycle. Okay, so this, for example, is a marathon runner who starts running 5 kilometers. Their Achilles and patella tendons adapt to that. They get stronger, tendon gets better, and they keep going around this cycle, no problem. Now, what happens if we have an excessive load, first of all, and then we'll talk about individual factors. So let's say we have an excessive load. So somebody who has never run before and they decide they want to do a 42-kilometer marathon. And they start running 10 kilometers and they have a big jump in load going through their tendons. What can happen is they can get, this is just different types of tendinopathy, they can get a reactive tendinopathy. So the tendon becomes painful and sore. Now, if they keep doing that, so then they run 20 kilometers and they run 30 kilometers, they progress down this tendinopathy continuum. But what you can see, which is really important here, and this is what we're going to try and do with our rehabilitation, is even when it gets sore, if we can get the appropriate load on it, we can come back to being a normal tendon again. And then hopefully, if we do the right thing, we can just stay in this little cycle. The other interesting thing, which is very, very common in what happens with tendon injuries, is you can also stress shield. So if you, let's say, have been playing football, doesn't matter what type, the season finishes and you do absolutely no running, no football training for a month, and then you come back. So even though you've been handling even though you're coming back to the same training, because you've had a break, your tendon has become different, stress shielded, and then you get a reactive tendinopathy. So what we want to do is normal tendon, optimized load, allow the tendon to adapt and repeat. And when we go into the principles of rehabilitation for them, all we're trying to do is, if we find ourselves coming down this path, we want to get the load back under control and come back to a tendon that's handling the load and go around this cycle. The other important thing here I'll talk about with the principles of rehab, excessive load will cause tendon pain, also individual factors. So if there's factors that cause you to have an increase in the load in the tendon, we'll need to address those, but I'll speak about those in a sec. Actually, I'll do it right here. So before I go through examples and the stages of rehabilitation for different tendons, I think this is really, really important. So this is the principles, and I think you apply these to any tendon, and the rehabilitation should sort of go, I think never that smooth, but should go reasonably smoothly if you apply these principles. So the first one is avoiding positions of compression initially, and I'll show you what I mean when I demonstrate some exercises. But tendons don't particularly like compressive forces. So with any rehabilitation, like I was speaking about last week with shoulders, we want to start with exercises and rehabilitation that is less demanding, and then we want to progress to more and more and more demanding. So we want to stay away from compressive forces to start with. We want to identify our objective markers, and I know there's been a couple of presentations on those, and the amount of pain that we're happy to have. Oh, hang on 1 second. I've gone too far. So amount of pain is tolerable. So I'll show you on one of my rehab plans later. So tendons do not have to be pain-free during rehabilitation. So the cutoff I often use is a 3 or a 4 out of 10. So if 0 is no pain, 10 is the worst pain you could imagine. I'm comfortable with a 3 or 4 out of 10 with tendon pain as long as it's not changing. Okay, so I'll explain that a little bit later when we go to rehab. So as long as the pain is not changing, so what we want, for example, is to be able to do our rehabilitation, have the tendon being 3 out of 10 pain during the session, and it doesn't get worse and it's not worse the next day, I'm okay with that. If 2 days later we do another rehab session and they do more work and they still have a 3 out of 10 pain, I'm okay with that, as long as we're doing more and more activity to get the same amount of pain. So it's up to you to work out what the pain level you're tolerating. As I mentioned, what tendons need very, very slow progressions from less to more demands. So tendons adapt very, very slowly. So we need really, really slow progressions. We can't go from running 3 kilometers to running 30 kilometers. We might need to really, really slowly step that up. And that might be the same with swimming. You might go, it's reasonably common to get tendinopathies in your shoulder from swimming because it's a repetitive activity. So slow incremental change is what tendons like. So that's really important with our rehabilitation, that we plan it out with slow step changes. What's really interesting for tendon pain is isometrics, which I'll show you. They result in pain relief. So there's really good research that shows 45-second holds of an isometric, which I'll show you shortly, will give you immediate pain relief if the problem is a tendon. So that's really interesting, and it gives us diagnostic value, because if we look at somebody and we ask them to do an isometric hold and their tendon pain decreases, we know we're dealing with a tendon, and it gives them something to control their pain early on. We need to consider a 24-hour pain response. So if we give them something to do tonight, we want to make sure they're not worse tomorrow morning, because tendon pain often will do that, and address contributing factors. So often the problem is your pure overload of a tissue, but if there's a reason that's causing one area to be overloaded, for example, someone has an old ankle injury and a very, very stiff ankle, and we don't address that, it means that even when we get the tendon under control, when they go back to running, the stiff ankle will cause them to load the tendon as well. So we need to make sure if there's anything else that's causing them trouble, we need to address that as part of the rehabilitation. And my biggest piece of advice for tendon injuries is you've got to plan it, and then you've got to slow it all down. And that comes back to slow loading progressions. So I'll show you a bit of an example of a Achilles tendon plan that someone I know is following at the moment. So types of contractions. So some people will know this, some may not. Concentric muscle, and this is important with our rehab, which I'll show you. So concentric contraction is a muscle shortens during contraction. So if you imagine you're holding a shopping bag in your hand and you lift it up and bend your elbow, and you lift it off the ground, that would be concentric contraction because the muscle is shortening. If you held it up high and slowly lowered it down, so in eccentric contraction, the muscle lengthens during the contraction. So if you held it and you were slowly lowering it down until your arm became straight, that would be an eccentric contraction. And isometric is when the muscle length does not change. So if you're holding your elbow at 90 degrees, holding the shopping bag, and it wasn't moving up or down, that would be an isometric contraction. Okay, so before we get into demonstrating a few exercises, these are kind of the 4 stages that I use for any tendon. So it doesn't matter where it is anatomically. So these are the sort of stages that seem to work for me, and I've got these often a number of different people that know a lot more about tendons than me, and I've kind of adapted into this 4-stage process. So stage 1 is reducing the pain and begin loading. So like I said, tendons really like loading and slow progressive loading. If you just get someone with a tendon to do nothing, their pain might come down, but as soon as they start doing something again, it's going to come straight back. So reduce pain and begin loading, that's where the isometrics fit in. Like I said, if we give someone with tendon pain isometric exercises, that will help with their pain relief. So I'll show you an example of those. Once we've got that under control, then we start to go through exercises that increase the range of movement. So isometric when the joint is not moving. The next stage is to do exercise that goes through the range of movement of the joint slowly. Once we've got that under control, and again, this doesn't have to be 0 out of 10, but once we're going through this with a comfortable amount of pain, the next stage is to increase the speed. So we've got the range of movement back. Then we slowly increase how fast we do it. And then the last stage is getting the stretch shorten cycle. So that's the jumping, landing, plyometric type exercise, and back to sports specific movements. So tennis, it might be serving. If it was rugby, it might be running and changing direction, jumping, landing, that sort of thing. And what you can probably see in those progressions, if you think about it, what a tendon does is it starts from very low demand and goes all the way through to very high demand activities. So what I want to look at is I want to look at an exercise for all 4 of those stages for 3 different areas. So I can stop sharing this. So I want to look at, so an exercise example that I use for all of those stages for 3 different areas. So we'll look at an Achilles tendon on the back of your ankle. We'll look at a patella tendon, because I think they're the 2 most common that certainly that I see, and they're probably the most common anyone sees, I guess. And then the third one is a supraspinatus tendon. So that's a tendon in your shoulder, which is common in swimming and throwing sports. So these, first of all, are not the only exercises to use, but they're the ones that I kind of think work reasonably well. So stage 1 is those isometric exercises. So generally, if you read the research about tendons, 4 or 5 lots of 45-second holds is what is providing pain relief. So I'll show you the first one for an Achilles tendon. Now, the other thing we need to bear in mind is, if you remember earlier, I said we need to avoid compressive forces. Okay, so hopefully you'll see that. So with an Achilles tendon, at the back of your ankle, if we go off a step and drop our heels all the way down, we'll get some compression underneath the Achilles. The same as if we come all the way up on our toes right at the top, you can see how we can get some compression on the tendon as well. So what we do is we come halfway. So if that's all the way down, that's all the way up, we come halfway up and we hold it. So again, isometric contraction for a tendon is when the muscle is contracting. You can see my calf's contracting, but there's no movement happening. Can you see if that was moving, an isometric calf contraction is going to be halfway up and hold. So we're loading the Achilles tendon, but not through movement. Now, again, like I said earlier, what we're trying to do when we do this is we want to get a 2 or 3 out of 10 pain. So if someone could do this and they had no pain at all, we might make it more difficult by saying, okay, well, what if you just stood on your left foot? Does that give you a bit of discomfort? Does that make sense? Hopefully. So that's a very easy example for an Achilles tendon. Patella tendon. So patella tendon sits at the front of your knee and it attaches your quadricep muscles to your patella. Through your patella down to your tibia. There's 2 ways that I use this. So again, what we're trying to do is we're trying to do an exercise that's mid-range, because if we're all the way bent up or all the way straight, we get compressive forces. So we want to do an exercise that's in the middle of the range of the knee, and you're holding it without moving. So there's 2 examples I use here. So the first one is just with a reasonably heavy TheraBand tied to something, or a knee extension machine. I get them to come to the middle of the range, and hold it there. The same thing, if they're going through range, it's probably not going to help them early on in the first stage, but they can come halfway and hold. And the same thing, we're loading the tendon without moving it. Another one that works quite nicely for patellar tendons is called a Spanish squat. So with a band around the back of the knee, walking back, so there's quite a bit of resistance, and going into a squat position, the band pulls your knee forward, which puts a little bit more load on the front of your knee. The same idea, we're holding a middle position, so we're not all the way bent and we're not all the way straight. Mid-range, holding the position without moving to load the tendon. So that's a stage 1 exercise for a patellar tendon. And for a shoulder, so your supraspinatus tendon's main job is an external rotator. So again, if this is in the middle of the range and that's the outside of the range, you want to come halfway and do an isometric contraction. So the easiest way to do that with a TheraBand or with a cable machine is coming halfway and again holding. So we're looking at that 45-second holds in that position. So that's some examples of stage 1 exercises. So remember, in stage 1, we're looking at isometric contractions that help with the pain relief. So once we get that under control, the next stage we often look at is stage 2 of rehabilitation. And this might take, for some cases, again, I'll show you an example of a rehab I'm doing at the moment. But the timeline might come from, it might be anything from, I don't know, 2 weeks to 6 months, depending on the tendon, depending what they need to get back to, depending on the demands of the sport, depending on their history, all sorts of things. But these 4 stages remain consistent. The length of time in them is what's challenging. And again, what we're trying to do is do more loading activity through the tendon for the same amount of pain or less pain. So that's some examples of isometric contractions. So stage 1 exercise for an Achilles tendon, patellar tendon, and a supraspinatus tendon in the shoulder. The next thing we want to do, once we've got the pain under control and it's stable over that 24-hour period that we're looking at, the next thing we want to do is you want to start to get some exercise through the tendon, through the range of movement that the joint does. Now, tendons don't like quick explosive movement, so we need to start really, really slowly. So if we go back to an Achilles, what we'll often get them to do. So again, we want to avoid compressive forces. So I often start this just with your feet flat on the ground rather than off a step. And they might just be doing double leg calf raises, but I get them to do it very, very slowly because that's less likely to aggravate the tendon. So I often say 3 seconds up to the top. They pause there for a second and then 3 seconds down. And all we're trying to do, so we know that by this stage they can handle holding that position. We want to start to get some slow movement without aggravating the tendon. So if we go very, very slow through the range, we'll start to get some exercise through the joint without aggravating the tendon. And again, we can progress out to going, obviously, single leg, slowly. And then once they can handle that, that's when we can increase the range further by going off a step. So if we go off a step, obviously we come up the same way, but we go below the ground level into more ankle range. And all we're trying to do in this stage is progress our loading going through more range. For a patellar tendon, we can often use the same exercise and just start to progress them. So if we go to our knee extension to start with, so we know by this stage they can hold comfortably, what we might start to do is ask them to go through range. So they might start just going to halfway and back, because we know that's less likely to compress them. Slowly again, so it might be 2 or 3 seconds with a pause, just in the range they're comfortable. And then we might start to go through all the full range. Again, if we look at that Spanish squat, what we can then start to do, obviously, is load them in a position they do, and then we can start to go through some range again. So they might come down to 90 degrees and just work in the inner range very, very slowly to avoid the compressive forces. And it probably seems pretty straightforward and obvious by now, but again with the shoulder, same sort of thing. So we know they're comfortable holding here. What we then might start to do is work through range. Again, early on, we want to be really, really slow and controlled, which is less likely to aggravate the tendon and more likely to load it. And we know the load is what helps tendons. So the same segments, same story, might be going 2 or 3 seconds in, 3 seconds out. Once we've done that, so that's stage 2. The third stage in this rehab plan is then we want to start to add a bit of speed. So by this stage, we know that isometrics give them pain relief. We know that they're able to use their tendon through range by now and their pain is under control. But moving slowly is not enough to run. It's not enough to go back to sport necessarily, because obviously it needs to be able to handle demands that's a lot faster and a lot more explosive. Even walking fast, jogging needs to be handled. The tendon needs to be handling multiple body weights and be able to do that quite quickly. And this is where I think often rehabilitations fall down. They get to this stage and they're going really, really well, and they try and go too quickly to get back to doing those activities. So we want to then slowly increase the speed. Okay, so again, if I show you some examples, what I often actually do for Achilles tendons is I get a book on the ground. So again, we're trying to limit their range, and I try and get them to do pulses. The heel doesn't touch the book, and they do it quite quickly. So sometimes I often get them to set a metronome on their phone, 120 beats per minute, which is quite fast if you have to go at it. And what we're trying to do is, we know that they can hold by this stage. We know that they can go slowly through range. Now what we're going to do is try and get them to go faster, so the tendon is getting used to going quickly, but not going to a position that it doesn't like. So I call them pulses. Again, it might be both legs. It's easy to see one leg, where they're just going up and down at a faster pace, so the tendon is getting used to handling the elastic load. And again, I think this is one area that's often missed with Achilles tendon rehab. What we might do with the patellar tendon, an example of an exercise in this third stage where we're starting to increase the load, is we might go to single leg, and we might get them to go. So again, we know that this might aggravate them because it's the end range compressive, and we know it might aggravate them right down here, but we can stay in the middle, same thing, get them to doing pulses. Or we might get them to step forward, lunge, and push back. And again, what you can see is as they're stepping forward, they're having to absorb some impact. There's a bit more speed in the movement, and they push back, which is going to be, which you can see is a progression from slow squatting movements to starting to take the load faster and start to reintroduce them to what they're going to need for running. An example for a shoulder, I use a tennis ball or even just a roll of tape. So that's the Elastoplast 38mm tape. Is once we've got their rotation strength going well through range, we want to increase the speed. What we might do is get them to just drop and catch something in this position. Now, all we're doing is external rotation, but we're doing it up here instead of down here. And if you saw when I was speaking about shoulders last Thursday evening, once we progress through range, we often work up here because it's what they need for various sports. And what we're doing, so we might be using external rotation strength, but in terms of increasing speed, having to drop and catch something starts to use the muscles a lot faster. Okay, and with that goal of this third stage is just that we know that they've got strength in one position, strength slowly through range, we're starting to get the speed back. And you can see how that becomes a little bit more relative for throwing sports, swimming, when they're going a little bit faster. And then the fourth stage, so again, if we go back to those 4 stages, the last stage of the rehab is looking at starting to add plyometrics or sport-specific movements. So examples of those for an Achilles tendon is that might be skipping, so using a skipping rope. So obviously that's, by that stage, we know they're strong, they're going through range, so that's skipping on the spot, so it's quite fast and it's reactive, and it might be getting back to sprinting or changing direction. And you can see how by that stage, that's the final thing we need to work on before they return to sport. For a patellar tendon, that might be slowing down. So patellar tendons don't like decelerating that much. So the last thing they might do before they return to sport is sharp acceleration, slow down, and change direction. So we need to retrain these things before they go back to sport. For a shoulder example, so we know they can hold here, we know they can throw up here, we need to then increase the amount of throwing or increase the amount of swimming they're doing. So that's reasonably quick, but you can, what I would hope is you can apply those principles to anything. So another common tendon injury is tennis elbow or golfer's elbow, which people talk about on the inside or outside of the elbow. And you can apply those principles. So what you might start off doing is an isometric contraction before you start to do contractions slowly through range, speed them up, and then go back to what the activity requires. So what I'm going to do, if you just bear with me for a second, I'll just pull up an example of an Achilles tendon rehab, just to show you a bit more to do with the plan. Okay, so hopefully you can see this. This is just an example of a couple of putting this into a different format. So this is just an Achilles tendon rehabilitation program. There's 1, 2, 3 weeks at the moment. So what I want you to notice with this is the first line is isometric. So like I said, what we want to do in stage 1 is you want to give isometric exercises so that they give pain relief for the tendon. So you can see what we start with is 3 lots of 30 seconds, and we alternate and we slowly build up to 40 seconds. And you'll see over the second week, we're doing 40 seconds single leg, where we're doing double leg in the first week. Now, the other thing that's really important with rehabilitations is that we're trying to load it, give it time to recover, load it, give it time to recover. So what you can see is some days are high, then we give it a couple of days to recover, then we give it a high load day, let it recover, high load day. So again, what we're looking at to start with is isometrics, like I mentioned. So early on stage 1 is isometric exercises for pain relief. They're doing those every day because we know that for this tendon injury, it helps with the pain. So you can see they do isometric holds before any running session. They do them every day. Then after the running sessions, they do strength exercises. If we go to the second week, what you'll see is we start to then increase the amount of exercise that's happening. So then as we go into stage 2 and stage 3, we start to go into calf raises. So at stage 2, I mentioned we want to go off a step to increase range, for example. That's when we start to bring in increased range of movement for the tendon. So we maintain isometrics for pain relief, and then we start to increase the range, which you can see there. So we're going off calf raise, but we've added a step in. We're still going slowly, 3 seconds up, 3 seconds down. You can see here on the first day of the week, slowly up, slowly down, but through more range. And you can see the back end of the second week, so once we've got isometrics under control, stage 2 is starting to increase the range. Stage 3 is starting to increase the speed. So you can see once we get to stage 3, we then look at the pulses off the step at 120 beats per minute. Okay, so that's where we're up to with this person at the moment. So that's a little example of an Achilles tendon. So what we're looking at there is we've started off with isometrics early on for pain relief. Once the pain settled down, we've started to do exercises through range. So we started doing calf raises with the foot flat on the floor, and then we've progressed that by starting to go off a step. So we go through more range. Once we're doing that and when the pain is under control, then we're starting to add speed. So we're adding some hopping, landing, or some pulses. And the last stage is starting to get back to sport-specific activity and the plyometrics. That might be skipping, jumping, landing, sprinting. So like I said, with Achilles tendons, with tendinopathies, they're on a continuum. And if we follow those principles, the rehabilitations generally work reasonably well. But my top tip, I suppose, is to really, really slow it down and take really, really slow and gradual progressions. So if anyone's got any questions on tendons at all, I'm happy to answer them. So the first one. Okay. So the question is, what sort of time frame for rehab would you expect for a minor tendon injury compared to a complete tear? So it's really hard to put time frames on tendon injuries, but if we talked about a complete tear, so a rupture of a tendon, so a rupture of an Achilles or a patella tendon, they take a long time to get over, because if you imagine, first of all, they surgically have to be repaired. So if the tendon is ruptured, they need to be put back together, and they need to have time to get stiff. So if an Achilles tendon, what they'll do is they'll repair it. They need to put it in a plantar flex position. So first of all, you've got to get all of your range of movement back, and then you need to do all of this loading very, very slowly. So that might take 9 months. So you're looking at sort of 9 to 12 months if you completely rupture a load-bearing tendon. So your patella or your Achilles would be 9 to 12 months, I would say. If we're looking at a tendinopathy that came on quite quickly and hasn't been hanging around for a while, so you saw someone and they said the last week my Achilles just started to get a little bit sore, that would probably settle down over 1 or 2 weeks. So I would say on average tendinopathies are probably somewhere between 6 and 12 weeks, ballpark, but a tendon rupture is significantly longer. That's more likely sort of 9 to 12 months. Another question, do you aim to build muscular strength in the tendon? So for example, high load, low reps before adding speed. And I think that's exactly right. So what we want to do is get the tendon to adapt to load. So yeah, so quite a lot of load on it, but low reps and low range to start with, and then we add speed. That's exactly right. So if we look at those 4 sort of principles, stages that I tend to use, and there's lots of ways to do it, but I tend to do that. So lots of heavy strength work in first, then add range, then add speed, then return to sport, because they're more and more demanding tasks for a tendon. Do most tendon injuries require some form of taping when returning to play or even during the rehab process? Interestingly, they don't. Tendon injuries are quite difficult to tape, because often what you're doing with rigid tape is you're trying to limit the movement of a joint. But with a tendon, you want the joint to be going through full range. So the exception to that would be rock tape or kinesio tape or some sort of elastic tape. Sometimes they play a role in tendons because they give them a bit of support, but it's very rare that a joint would be taped to prevent movement for a tendon injury, because tendon pain is not a stability issue, if that makes sense. And generally taping is for stability. Like I said, the exception would be some sort of elastic or stretchy tape that can be used for tendons to give them some support. What stage so the next question here is, what stage do you work through full range and begin to expose the tendon to those compressive loads? That's a really good question. So once they're going, I think, so the second stage is when I start to add range and I slowly increase it. So the compressive loads are generally at the end of each range. So I would slowly work into that. So again, with the Achilles, they start with calf raises off the ground. Then I slowly increase the range by putting them on a step, which takes them into a compressive range of movement. So I would just slowly do it as I increase range, which is the second stage. Okay. Next question, how frequently do you recommend is spent on the rehab process? So sessions per week and duration of sessions. Again, it's a tough one. I think a lot of it is putting together a plan and getting the principles there. So I think often people can do that by themselves as long as there's a plan in place. So maybe, if you're seeing someone once a week, to be able to put together a plan for them to follow, you might just need to adapt it week on week or every second week if it's going okay. The issue is that the plans often need tweaking. So you put together a plan and they become too sore, and you might need to pull back a little bit, or they're not, or you can progress them faster. So I think the best way is to see people regularly, to check in with how they're going and adapt the plan as needed. This is an interesting question. So there's some conflicting advice on anti-inflammatories. Where do you sit on this? So I guess where that's coming from, which I'd mentioned but probably didn't answer in the end. It used to be called tendonitis. The reason I'm calling them tendinopathies is, if we go back to that anatomy, there's some evidence now that it's not actually an inflammation of a tendon, which is what tendonitis implies. It's actually a thickening of a tendon, and it's a cellular change. So if you believe that, which I think is where the evidence is now, anti-inflammatories probably don't help tendon pain. Probably the other thing that's relevant to mention here is so cortisone injections, which are quite rare. So there's a school of thought that if you put cortisone, which is a strong anti-inflammatory, around a tendon, that potentially it weakens it, and that's a dangerous thing to do. So that's something that the doctors need to consider if they're doing that. So I think, in my experience, anti-inflammatory is not that helpful for tendon pain because it's not an inflammatory condition. So next question, would you recommend isometric movements in a non-rehab training plan? So could this assist in preventing tendon injuries? Maybe. I don't think there's certainly no harm in doing heavy isometric exercise, I don't think, at any point. The question is, does it help you? I don't think it prevents tendon injury. I do think what tendons like is consistent load. So to answer your question in a different way, I think if you've had a history of a tendon injury, you need to be loading it all the time. So if you play a sport in the off season, you need to be running once or twice a week, for example, just to be loading it consistently. So I don't think it prevents it, but I think it's important that tendons are consistently loaded to avoid that spike in load that gives you the pain. But yeah, I don't think there's no downside I can think of with heavy isometric exercises. It puts tissue under load that's got to be helpful for it. So there's certainly not a negative, I would think. Okay, so that's pretty much our time. So so thanks everyone that's logged in for tonight. So like I said, that's week 5, session 9. I wrote for the Elastoplast taping and movement series. So that was my sort of take on tendon injuries and rehabilitation. I hope that's been useful. And if you need information, obviously go to elastoplast.com. But thank you all very much for spending your Thursday evening with me, and I hope that was useful for you.